Hey y'all, it is Tara Dennison. I am going to go over chapter 14, Nursing Management During Labor and Birth. Basically, the health of mothers reflects the current health status of our population and predicts the health of the next generation. So one of the big issues right now in healthy people, 2020, is reducing maternal deaths and reducing maternal illness and complications of pregnancy. Also increasing the number of pregnant women receiving early and adequate prenatal care, and increase the number of pregnant women attending prepared childbirth classes. So with the maternal assessment during labor and birth, this is just a picture of basically a vaginal examination. And as a practitioner, it takes a pretty good amount of time to get your own assessment skills up to par for a vaginal exam. Basically, the vaginal exams, and you don't do them a lot because it can always increase the risk of infection, but those vaginal exams are basically to see how far down the baby is, what position that they are in. Basically, there's the station, the presentation, and it does take time. And please make sure that you understand that you are touching someone in a very, very uncomfortable spot. Number one, she's hurting. Number two, this is probably, sometimes it's new to them. So just explain to mom what all that you are doing. Basically, you're going to be assessing the dilation, how far the cervix has dilated, the effacement, which is how far the cervix has thinned, the station, the flexion, the swelling, the molding. Make sure that you use sterile gloves and a water-based lubricant, and always discuss your findings with mom and her family. Document your findings and let her provider know if there's any kind of issue. Now, cervical dilation is a subjective finding. All of our fingers, all of our hands are small or different sizes. I have really small hands. Somebody else might have really big hands. Some might have really thick fingers. Some might have really skinny fingers. So it's very subjective, but you're going to be the only one, pretty much, other than the practitioner, that is doing this assessment. So it's fun. So you're going to be assessing mom's status, her vital signs, her pain, basically the prenatal record review. So again, with the vaginal examination, you're going to gather info on all the things, the presentation, the position, station, which we'll talk about in further detail later. Rupture of membranes. So if the membranes, also called the water bag, if it is intact, the membranes will be felt as a soft bulge that is more prominent during a contraction. After the rupture of membranes, priority assessment, please don't forget this. Priority assessment is the fetal heart rate. This is to assess for deceleration, indicating cord compression. We don't want that cord to be compressed. Now also, prolonged ruptured membranes will increase that risk of infection. Normally, the membranes rupture during the first stage of labor. There are little swabs that it's a nitrazine yellow dye swab. It is used to determine the pH of the fluid. If that fluid turns blue, if the swab turns blue, it's probably ruptured. Now, uterine contractions, there is a building up or an increment, reaching an acme, peak intensity, that's the tallest that it has reached, and then a letting down, which is a decrement. Contractions with an intensity of 30 millimeters of mercury or greater will dilate that cervix. So you want to make sure that those contractions are good and strong. They can actually reach up to 50 to 80 during active labor. So how you can kind of feel and how you will document the contractions. So with the tip of your fingers on the fundus, you're going to describe how it feels. So during a contraction, so if the fundus feels like the tip of a nose, it's a mild contraction. If it feels like the chin, it's a moderate contraction. Or if it's like the forehead, it's a strong contraction. Now, Leopold maneuvers basically determine the presentation position lie, and it goes through 4 different steps. So you're going to place both of your hands on the abdomen to feel the fundus. The buttocks of the baby will feel soft and irregular. That's going to indicate a vertex presentation or the head down. You're going to feel for the head. That head's going to feel hard and smooth and round. If you feel the head up in the top, then that usually indicates that they are in breech presentation. Then you're going to move your hands down the lateral sides of the abdomen to feel which side the back is located. It feels hard and smooth, the back does. Now, limbs will feel like irregular nodules with kicking and movement. Next, you're going to grasp the lower segment, uterine segment, and you're going to palpate the area just above the symphysis pubis. You're going to place the thumb and the fingers of one hand apart and grasp the presenting part by bringing the fingers together. If it's the head, it'll be round, firm. If it's the buttocks, it's going to be soft and irregular. Now, once the membranes rupture, the amniotic fluid should be clear. You never want to see green or brown color of that amniotic fluid. Basically, you're going to figure out if the membranes are intact, if they're ruptured, bulging, was there a gush or trickle, any color, odor, what is the fetal heart tone. You're going to check for a prolapsed cord. When did that rupture of membranes occur? How long ago? You do not want it to go over 24 hours because that, number one, can increase the risk of infection, but also that baby is going to be, it's going to increase the risk for cord compression because it doesn't have that fluid to kind of buffer that environment. So down here at the bottom, I've put a picture of an amnio hook, and basically what they do is they take that, you see the little end right there, they take that and they just kind of hook it into the membranes to rupture it. So sometimes, if a woman is not progressing, if her water is not broken, membranes have not ruptured, then they will actually go in and do that. This is a fetal stimulator. Basically, you put it on the outside and you're hoping to see accelerations on that fetal heart monitor. So also the fetal heart rate monitoring, there is handheld that you can put on the side of the belly, listening on the back. That's intermittent, basically. Also electronic is basically 2 different things that go on the outside of the belly. One will have the gel. The other one will basically be assessing the contractions and how strong that they are. We'll go over fetal heart rate patterns in more detail, but basically the object of fetal heart monitoring is to reduce the mortality and morbidity by ensuring that all fetal hypoxic insults are identified in time to allow removal or alteration of the reason for the hypoxic insults, and possibly need to take mom to surgery as soon as possible. And then, for low-risk women, the fetal heart rate should be assessed every 15 to 30 minutes during active labor, every 5 to 15 minutes while pushing. Continuous monitoring, she's going to end up having to kind of stay in the bed. It's hard for her to get around and walk with everything attached to her. So it's, for low-risk women, it's better to have intermittent, just so that she can get up and move. So guidelines, basically initial 10 to 20 minute continuous fetal heart rate assessment on entry into the labor birth area. The electronic fetal monitoring visualizes the fetal heart rate patterns on a screen or printed tracing. It's the primary mode of intrapartum assessment. Make sure you explain to the family and the patient what you're doing, what's going on, about the equipment, the benefits and the limitations. So when the monitoring device is in place, a sound is produced with each heartbeat, producing a graphic record of the fetal heart rate pattern. Because labor is a period of physiological stress for the fetus, frequent monitoring of that fetal status is an essential part of nursing care. So not only do you have mom, you also have baby. So you're taking care of two people. Fetal oxygen supply must be maintained to prevent fetal compromise and to promote newborn health after birth. Now, fetal oxygen supply can decrease because of reduction of blood flow through those maternal vessels. This can be caused by hypertension, could be pregnancy-induced hypertension, chronic hypertension, hypotension, so the position of mom if the baby's laying on the aorta, hemorrhage, if there's an epidural, it can also reduce the blood flow, or hypovolemia. Reduction of oxygen content in maternal blood. So if mom is severely anemic or if she is experiencing a hemorrhage. Also an alteration in fetal circulation. So this can occur with a cord compression, which can be during contractions or can be a prolapsed cord. Placental separation, head decompression. This causes the vagal nerve stimulation. Also reduction in blood flow to the intervillous spaces in the placenta. This can be secondary to uterine hypertonus or excessive exogenous oxytocin, or secondary to the deterioration of placental vasculature. That can be caused by maternal hypertension or diabetes. So when she gets there, you're going to complete a prenatal and labor risk assessment. If she's low or if she's high risk. And then during the second stage, every 15 minutes for low risk women and every 5 minutes for high risk women. Now, when we talk about the continuous electronic fetal monitoring, basically the criteria for this is the membranes need to be ruptured already, cervical dilation of at least 2 centimeters. The present fetal part needs to be low enough to allow for placement of the scalp electrode, and a skilled practitioner needs to be available to insert a spiral electrode. So the continuous, basically, it has a little electrode that kind of attaches to the infant's head. It has a little bitty needle, and just kind of like, it don't hurt the baby. It just kind of goes directly in. There's so much fluid and there's so much lubrication that it's hard to get that, you know, to stay if it's just sticky. So it has to have a little bit of a pressure. So basically you will see an electrode inside a mom, and that is going to be the best way to monitor that fetus. This is for women or fetuses at high risk or with multiple gestation, increased fetal movement, abnormal fetal heart rate on auscultation, intrauterine growth restriction, maternal fever, or preeclampsia. Diabetes or hypertension can also increase mom's risk, so she may need to have this. So that intrauterine pressure catheter, as you see right here, that is placed into the uterine cavity. That just monitors that the feel of the contractions. It monitors much better. And then the fetal scalp will be monitoring the baby's fetal heart rate. So this is not like the greatest picture, but I just wanted to kind of give you an idea of what you're going to be seeing when you do go into the labor and delivery department. So this is a fetal heart monitor, okay? And this up here is the baby. This down here is mom. So these are those lovely uterine contractions, okay? So then the baby, this is their heart rate. This is the baseline heart rate right here. So what you want to see is variability. So you want to see some movement, some waves, just to kind of knowing that that baby is moving, that baby's heart is going up with, you know, or down or however. So in between these two red lines represent 1 minute. And you'll see these little boxes, you can't really see because this stupid picture, but these little boxes are 10 seconds at a time. So that helps you to see how far apart those contractions are, and really how that variability is going. So the larger box is 1 minute, the small square box is 10 seconds. So you are going to be monitoring the frequency of the contractions. So usually there's 2 to 5 per 10 minutes during labor. They remain fairly stable throughout the first and second stages from 45 to 80 seconds, not generally exceeding a contraction lasting 90 or more. Intensity is generally from 25 to 50. That's in the first stage, which can then rise over to over 80 in the second stage. Resting tone, the average is 10 millimeters of mercury. It should palpate as soft. That is before the contractions occur. So, if you see, again, this is the baby, right? This is mom and her contractions, right? So with these contractions, there's different phases. So starting here is the increment, okay? And then it goes up, up, up. Here's your acme. That's the tallest. That's when it's just the most painful, okay? And then those contractions start going down, and that is the decrement. And then this is the resting period down here, okay? So this is where mom is not contracting. So frequency is the beginning of one contraction to the beginning of the next contraction. So that's here to here. Duration is how long it lasts from beginning to end. So the way that you measure that is, this is 10 seconds, okay? Intensity, of course, that's the strength by palpation, if external or internal pressure capped. And see, this over here on the side will tell you how strong those are. So they'll reach up to about here, somewhere in here during the pushing and the active phase of labor. So there's 4 categories of baseline variability, which I'll show you in just a minute. When we talk about variability, it's basically you want that line to be fluctuating, okay? You don't want it to be a straight line. You don't, because if you think about it, the heart rate will go up when they're moving or when they're squeezed or when mom moves around or changes position. So you want to see that variability in that baseline. You want to see the changes in that baseline. You don't want to see that flat line. So the way that you document it, so if it's absent, that means there's no detectable fluctuation range. Minimal is usually observed at less than 5 beats per minute. Moderate is normal. That's the fluctuation range from 6 to 25 beats per minute. And then marked is fluctuation range greater than 25 beats per minute. And you have basically periodic baseline changes that are changes or trends of fetal heart rate over time. We'll go into more detail. So basically that baseline fetal heart rate is the average rate during a 10-minute segment that excludes periodic or episodic changes such as tachycardia or bradycardia. It's assessed when the woman has no contractions and baby is not experiencing an episodic fetal heart rate change. There must be at least 2 minutes of interpretable data in a 10-minute segment. After 10 minutes, you're going to round that to the closest 5 beats per minute. Normal range at term is 110 to 160 beats per minute. Preterm baseline is higher depending on the week's gestation. Variability is the best indicator of fetal status. Of course, you want them to be moving. You want their heart rate to be going up and down. Now, when that fetal heart rate accelerates, that indicates an intact central nervous system. It also indicates a pH of greater than 7. There needs to there's 4 criteria that must be met before those internal electrodes can be placed. Basically, mom, her position changes and movement do not interfere with the quality of the tracing. So the early decels or decelerations in the heart rate, that's the lowest point occurs at the peak of the contraction. This is most often seen in the active stage during pushing, crowning, or vacuum extraction, and it's thought to be due to the fetal head compression that results in the vagal response. These do not require intervention. These are benign. Early decelerations are fine. We're good with that. It's fine. Late decelerations, however, These occur after the peak of the contraction, and they are associated with uteroplacental insufficiency. This occurs when the blood flow is decreased, causing fetal hypoxia or myocardial depression. These can be caused by maternal hypotension, gestational hypertension, placental aging, secondary to diabetes and post-maturity, hyperstimulation from oxytocin infusion, maternal smoking, anemia, and cardiac disease. These recurrent or intermittent late decels are always category 2 or 3, which we'll look at in a minute. Variable decelerations, these are abrupt decreases in fetal heart rate below baseline and unpredictable shape, usually without any consistent relationship to uterine contractions, usually look like a V or W. These are usually correctable, usually associated with cord compression, and these are always classified as category 2 or 3. Sinusoidal pattern has a smooth sine wave-like pattern. It's rare. It's attributed to severe issues with the central nervous system and severe hypoxia. Always a category 3. To correct it, a fetal intrauterine transfusion would be needed. So this is just a picture of the fetal heart rate variability. Basically, you've got your absent, see how it's just straight. You have minimal, which is less than 5 beats per minute. As you can see, just a little bit minimal. Moderate is what we want to see. So we're going. Marked is a little bit too much. So we probably need to lower that oxytocin transfusion, change mom's position, do different things. Absent or minimal is usually caused by fetal acidemia. Basically, you need to place mom in the lateral or side lying position, increase her IV fluid rate, administer oxygen, and consider internal fetal monitoring. That is for the absent variability. For moderate, we're good. We're fantastic. Marked is usually by cord prolapse or compression, maternal hypotension, uterine hyperstimulation, and abrupt placenta. You're going to want to put her in the lateral position, increase her IV fluid rate, administer oxygen, and discontinue that oxytocin. These are the 3 different categories. A category 1 is predictive of normal fetal acid-base status, requires no intervention. Their heart rate's 110 to 160. There's moderate variability. There's present or absent accelerations, whatever. There's present or absent early decelerations. It's great. No late or variable decelerations. And basically can be monitored with intermittent auscultation during labor. Now, category 2 is it's not predictive of abnormal fetal acid-base status, but it does require evaluation and continued surveillance. So this is when baby's heart rate is greater than 160 or less than 110, absent variability, minimal or marked variability, recurrent late decelerations with moderate baseline variability, and then category 3, fetal bradycardia, less than 110, recurrent late decels, recurrent variable decels, or sinusoidal pattern. These are interventions that we do for category 3 patterns. Of course, you're going to notify the healthcare provider, make sure you document everything. You're going to discontinue the oxytocin. If it's being administered, turn her on her right or left side, knee to the chest, or hands and knees to increase placental perfusion or relieve that cord compression. Giving her oxygen via non-rebreather face mask to increase fetal oxygenation, increase IV fluid rate. That's going to improve intravascular volume and hopefully correct that hypotension. provide reassurance, assess them for any contributable causes, modify pushing if she is in the second stage of labor to improve fetal oxygenation, and prepare for a surgical birth if that pattern has not corrected within 30 minutes. So, if you see this is long-term variability, this is an acceleration. We like those. Baby's heart rate is going up. We're moving, we're happy, we're doing all the things, okay? So that's in conjunction with her contractions, looking good. So baby's heart rate's going up, okay? That's a good thing. Tachycardia is when that heart rate is above 160. So if you notice that baseline, that straight line pretty much from where their base is, it's greater than 160, and it lasts for a duration of 10 minutes or longer. It can be an early sign of hypoxemia, especially if it is associated with late decels and minimal or absent variability. It can be caused by maternal or fetal infection, prolonged rupture of membranes, amnionitis, maternal hyperthyroidism, fetal anemia, or in response to certain drugs such as atropine, Vistaril, terbutaline, cocaine, and methamphetamines. This is fetal bradycardia. This is a baseline fetal heart rate less than 110 for a duration of 10 minutes or longer. True bradycardia occurs rarely, and it is not specifically related to fetal oxygenation. It's often caused by fetal cardiac problems, such as structural defects involving pacemakers or conduction system. Other causes can be viral infections, maternal hypoglycemia, and maternal hypothermia. So this is a deceleration. If you notice how it goes down, there's an acceleration, that's good. Deceleration, deceleration. So these are caused by dominance of the parasympathetic response. It may be normal, may be benign. It's categorized as early, late, or prolonged. And they're described by their visual relation to the onset and end of a contraction, and also by their shape. So types of decelerations. Early decelerations, they are visually apparent, gradual. So the onset to the lowest point is 30 seconds, okay? And they decrease in and return to the baseline fetal heart rate, and it's basically associated with uterine contractions, thought to be caused by that head compression and considered normal. So if you see, that is in total relation. So there's your acme, there's that nadir, the very bottom, and it is exactly in relation to that contraction. Same with this one, and same with this one. So that is your early deceleration. No treatment is necessary for this. It's sometimes called a mirror image of the contraction. These will occur usually during the contractions, during vaginal exams, or as a result of fundal pressure, and during placement of internal modes of fetal monitoring. Usually occurs during the first stage of labor when the cervix is 4 to 7 centimeters, sometimes seen in the second stage during pushing. Late decelerations, these are a gradual decrease and return to baseline associated with uterine contractions. However, it begins after the onset of the contraction, and the lowest point occurs after the peak of the contraction. Usually does not return to baseline until the contraction is over. It's caused by uteroplacental insufficiency. Persistent and repetitive late decels usually indicate presence of fetal hypoxemia, If it is recurrent or sustained, it can lead to metabolic acidemia, should be considered an ominous sign when they are uncorrectable, especially if it's associated with absent or minimal variability and tachycardia. So factors that can disrupt oxygen transfer to fetus: maternal hypotension, not enough blood's going to get to that fetus, preeclampsia, post-term pregnancy, amnionitis, small for gestational age fetus, maternal diabetes, abruption, placental abruption, and maternal anemia. So if you see, these are late, okay? These happen after that contraction starts, okay? And usually doesn't end until after that contraction ends. This is a terrible picture. I'm going to have to fix this at some point. So there are variable decelerations and prolonged. So variable is visually abrupt. So the onset to the lowest point is less than 30 seconds. The decrease is at least 15 beats per minute or below baseline. It lasts at least 15 seconds and returns to baseline in less than 2 minutes from time of onset. These can occur anytime during a contraction and are caused by cord compression. So they have a U or a V or a W shape. It's characterized by rapid descent and ascent to and from the nadir of deceleration. It may be preceded or followed by brief accelerations. These are known as shoulders, and it's a compensatory response to cord compression. Occasionally, variables have little significance, but recurrent ones indicate repetitive disruption in oxygen supply. Mostly these occur during the transition phase of the first stage or second stage as a result of cord compression. I'm so sorry. Prolonged is at least, these are the prolonged. These are a decrease, gradual or abrupt, in the fetal heart rate of at least 15 beats per minute below baseline and lasting greater than 2 minutes but less than 10 minutes. If it lasts 10 minutes or greater than 10 minutes, it's a baseline change. It's caused by, of course, disruption in fetal oxygen supply. If disruption continues, fetal cardiac tissue will become hypoxic, may be caused by prolonged cord compression, and benign causes can be pelvic exams, placing the electrode, or sustained maternal Valsalva maneuver. But see how long it takes, that deceleration, and then finally we come back up to baseline, or really a little bit higher than baseline. And then this is basically your contractions. So you can have mild, you can have severe, clearly. Mild is just this, not that apparent. Severe, and you say it's kind of a weird shape. That's also a weird shape. So pain is universal experience. Different people can handle pain, other people cannot. There is a mandate for pain assessment in all clients admitting to any healthcare facility, and there are numerous non-pharmacologic and pharmacologic choices available to mom. Basically, the physical causes of pain during labor include cervical stretching, hypoxia of the uterine muscle due to decreased perfusion during contractions, pressure on the urethra, bladder, and rectum, distension of the muscles of the pelvic floor, different perceptions of and behavioral responses to pain, and factors that influence pain response, such as culture. Some people, they do not even think about having medication to help the pain. That's that's just the way that their families' cultural, religious, ethnic values integrate. So this is just a picture of how the distribution of labor pain in the first stage is due to contractions, dilation, and effacement. Also, the T1 and T2 nerves can be mashed. Usually the discomfort is only with a contraction, usually pain-free between contractions, and it's usually visceral pain. It's diffuse and not really well localized. And then in the second stage of labor, it's usually somatic pain, so it's intense, sharp, burning, distension. Pain impulses are transmitted via the pudendal nerve through S2 and S4. That's the spinal nerve segments. These result from the stimulation in the skin, bone, muscle, and soft tissue. Distension and traction on the peritoneum and the uterocervical supports during those contractions is going to cause that pain. Pressure against the bladder and rectum, stretching and distension of those tissues, and lacerations of the soft tissue. Third stage is basically similar to the first stage. So many non-pharmacological measures for pain. Basically, labor support. Somebody there to support mom and encourage her. Hydrotherapy, ambulation and position changes, acupressure, attention focusing and imagery, therapeutic touch and massage, effleurage. So effleurage is a light stroking superficial touch of the abdomen in rhythm with breathing during contractions, which this can be interrupted by all the things that is on mom's belly for us to be monitoring that baby. So sometimes it's kind of hard, but it can help. Also, breathing techniques. So childbirth preparation methods, Lamaze, Bradley, Dick Reed. These will encourage patient confidence and her ability to give birth. Education is basically given, encourage mom to choose a technique that works for them. Focusing and relaxation techniques will help reduce the tension of stress. Breathing techniques, imagery, focus, and pleasant scent. Coaching mom, encouraging her to move around. Breathing techniques. There may actually have had education before they came in, so you're just going to be there to encourage her to continue those. You can model and breathe with the patients. All patterns begin with deep, relaxing, cleansing breaths and end with another deep breath exhaled. Greet the contraction and gently blow the contraction away. The pattern paced or pant blow is suggested 3-to-1 or 4-to-1 pattern, though it can cause hyperventilation, so they may need to breathe into a paper bag or cupped hands. You want to keep that respiratory rate less than 2 times normal to prevent any issues. Hydrotherapy, research reports that women use hydrotherapy can significantly reduce surgical birth rates, have a shorter second stage of labor, reduced analgesic requirements, and lower the incidence of perineal trauma. Hydrotherapy aids in the labor process, minimizes use of analgesic medication, offers fast and short-acting pain and anxiety relief, and is safe and effective. Risks are hyperthermia. That water needs to be mom's temperature. Risks of hypothermia, changes in maternal heart rate, fetal tachycardia, and unplanned underwater birth. But it can release muscle tension, promote well-being, Warm water stimulates the release of endorphins, relaxes fibers to close that gate control theory. On pain, promotes better circulation and oxygen, and helps to soften the perineal tissues. Also, it soothes the nerves in the skin. Usually initiated in active labor, mom needs to be at least 5 centimeters. Water should cover the abdomen, but the shoulders should be out. No contraindications with rupture of membranes, and also a handheld shower head against the areas of discomfort, such as the back, can also be useful. Acupuncture and acupressure. Pressure, heat, or cold is applied to acupuncture points called subos. Points have increased density of neuroreceptors and increased electrical conduction. Also, aromatherapy is really good. Also, acupressure, which uses the same thing as acupressure, though it uses needles. You must be careful with touch and massage during the later stages of labor because of the hypersensitivity. You should experiment during pregnancy to see what works best. Touch can be as simple as holding a patient's hand, stroking her body, and embracing her. Make sure you find out what the woman's preference for touch, who can, when, how, and her responses to touch. Consider culture. Some women do not want to be touched. Massage, head, hand, back, foot massage can reduce tension. And then, of course, that effleurage also. Pharmacologic measures, these should be implemented before the pain becomes so severe that catecholamine increases and labor is prolonged. You need to consider the effects on the mother, also the effects on the fetus. The well-being of the fetus depends on adequate functioning of the maternal cardiovascular system. Any alteration in this can also affect the fetus and cause problems. So maintaining the maternal blood pressure and respiration is very important. And you also need to consider the effects on the contractions. If they make the contractions not as strong, you're going to see a lag in the precession of labor. So systemic analgesia is typically administered parenterally through an existing IV line. Opioids, ataraxics, and benzodiazepines can be given. Opioids are morphine-like medications that cross the maternal blood-brain barrier to bind with those pathways that transmit pain signals to the brain. It provides central analgesic effects, increases tolerance to pain, but can cause respiratory depression related to a decrease in sensitivity to carbon dioxide. So you're going to use cautiously with respiratory or cardiovascular disorders. Also, these can delay gastric emptying, increase nausea, vomiting, inhibit bowel and bladder elimination. It's usually, if given to reduce pain in the first stage of labor, it can inhibit those contractions. If given too early, it may prolong labor and depress the fetus. And if given too late, it will not help the mother and may cause depression in the baby after delivery. It's usually not given after 8 centimeters dilated or within 2 hours of delivery. They now use a PCA pump. The patient-controlled analgesia pump usually lowers the total amount of analgesic used, and the patient appreciates that autonomy of self-administration. Ideally, birth needs to be less than 1 hour or more than 4 hours after administration. Narcan should always be at the bedside, just in case that respiratory depression or overdose happens. So you have Demerol and Sublimase. These Demerol was commonly used, but no longer is the preferred choice. The sublimase is fentanyl. It's short-acting, but very potent. More commonly used for epidurals. Morphine is not used much because of that respiratory depression. Dilaudid is very potent and can be given IV or IM. And then just make sure that you're watching for that respiratory depression. So antiemetics can potentiate the effectiveness of the opioid so that a lesser dose can be given. So promethazine or Phenergan can be given IV. Hydroxyzine or Vistaril has to be given PO or IM. But these can also increase sedation. Neither affects the labor progress, but can cause a decrease in fetal heart rate variability and possible newborn depression. Compazine is typically given IV or IM with morphine for sleep during a prolonged latent phase, that counteracts the nausea associated with those opioids. Benzos are used for minor tranquilizing and sedative effects. Given with an opioid is seen to enhance pain relief and reduce nausea and vomiting, but they do cause significant maternal amnesia. Examples are Valium, Ativan. Major disadvantage of Valium is it disrupts the thermoregulation in newborns, which is never a good thing. It makes them less able to maintain their body temperature. Also, Versed and scopolamine can be given. So these are different regional or basically local blocks. An epidural block usually is started with a dilation is within 5 centimeters. Obstetrical regional anesthesia, usually there's partial or complete loss of pain sensation below T8 to T12. Local infiltration is usually for an episiotomy or laceration repair. A pudential block is usually in the second stage for an episiotomy or operative vaginal birth. So here is a picture of an epidural block. Usually there's a combo of opioid with a local anesthetic, basically passed through the epidural needle and providing continuous access to the epidural space. This just kind of tells you when they put the needle in, where that goes inside of the spinal cord. With a spinal analgesia, they inject an anesthetic or like a cane, benzocaine, with or without opioids into that subarachnoid space, used frequently for C-sections, and it's usually given during the active phase of labor, which is greater than 5 centimeters. These are just advantages and disadvantages of an epidural. It does cause maternal hypotension, resulting in less cardiac output, lower blood pressure. It can cause fetal depression, all those things. This is a post-dural puncture. This is a post-dural puncture headache blood patch. So leaking of spinal fluid from the puncture site is a major causative factor. Can be caused by accidental puncture of the dura mater during an epidural because of a larger needle. Postural changes cause diminished volume of spinal fluid to exert traction on pain-sensitive central nervous system structures. Assuming an upright position triggers or intensifies the headache, and supine position achieves relief. It usually begins within 2 days of the procedure and may persist for days or weeks. hydration, bed rest, oral analgesics, caffeine, theophylline. These can provide symptomatic relief. But a blood patch is the most rapid, reliable, and beneficial relief measure. 20 milliliters of the woman's own blood is slowly injected into the lumbar epidural space, creating a clot that patches the tear of the hole in that dura mater around the spinal cord. So nursing interventions, you're going to observe her vital signs, observe her for pallor, clammy skin, leakage of cerebrospinal fluid for 1 to 2 hours after, a bandage and cold pack applied to the puncture site, bed rest 1 to 2 hours after, no aspirin or NSAIDs for 2 days, drink plenty of fluids, observe for signs and symptoms of infection at that puncture site, observe for any neurological symptoms such as pain, numbness, tingling in legs, difficulty with walking or illumination. Also avoid lifting, straining, and coughing. Nitrous oxide, also called laughing gas, can also be mixed with oxygen and inhaled at a low concentration to provide analgesia during the first and second stages of labor. Mom controls it, and it is self-administered, and it is impossible to overdose. Now, general anesthesia can be started quickly. It causes a rapid loss of consciousness. This is followed by, this is usually, it's rarely used for an uncomplicated vaginal birth, but all anesthetic agents will cross that placenta and affect the fetus. So this is pretty much for an emergency C-section or a contraindication to use regional anesthesia. So in the first stage of labor, a lot of times moms will call in. So when moms call in, you're going to find out that estimated date of birth. You're going to find out if she's had any fetal movement, count to 10. How frequent has she felt the baby move in the last few days? If there's any other signs of labor that she has experienced, her previous childbirth experiences, if there's any contractions, characteristic of contractions, is her membrane still intact? Has she had a bloody show? Is there a supportive adult in the household if she is alone? You're going to obtain an admission history when she gets there. Check any results of a routine lab test and any special tests. Ask her about her childbirth plan. Different women want different things. Some women are hell-bent that they will not take medication. They want to do it all natural, and that's fine. That's her choice. Just make sure that you ask her about that plan. Also complete that physical assessment. Body systems, vital signs, lung sounds, height and weight. You're going to check the fundal height measurement, any uterine activity, contraction frequency, duration, and intensity. Is the membranes intact or ruptured? What is that cervical dilation and degree of effacement? Fetal heart rate, position, station, and of course her pain level. Of course, you're going to check that fetal heart monitor. Also, lab studies such as a routine urinalysis, CBC, any of those other screenings that she has not done yet, and also assess her psychological status. Continuously assessing her knowledge, experience, and expectations. Vaginal exams, again, as less as you possibly can. Contractions, pain level, that fetal heart rate, the amniotic fluid. Now, you're going to explain to mom everything that's going on. That second stage, she's going to be very, very nervous. You're going to be checking that fetal heart rate, and And of course, how is she coping? Support that mom and her partner, supporting involuntary bearing down efforts, encouraging no pushing until the strong desire or until descent and rotation of the fetal head is well advanced, using maternal positions to enhance descent and reduce pain, and preparing for assisting with delivery. When mom stands, walks, that gravity will help that descent. You're going to cleanse the perineal area and vulva. You're going to assist with birth, suction the newborn, and umbilical cord clamping. And the immediate care of the newborn, you are going to dry them vigorously, check that APGAR score, and identify, put the identification on that matches mom's. So in the third stage, you're going to assess that placenta. You're going to examine the membranes. You're going to assess for any perineal trauma, if there needs to be an episiotomy, if there's any lacerations. You're going to instruct mom to push when the separation of the placenta is apparent. You may need to give oxytocin if ordered, assisting woman to comfortable position. Make sure she's warm because she may be shaking. Applying ice to perineum if an episiotomy is completed, and documenting birth. And so, of course, your assessment of the fourth stage, vital signs, fundus, perineal area, comfort level, lochia, bladder status, and those fundal checks are very important to make sure that she does not have a postpartum hemorrhage. So according to the ACOG, ICSI, and AWHONN guidelines, how often should the fetal heart rate be assessed for a high-risk laboring woman during the second stage of labor? It should be every 5 minutes for the high-risk mama and every 15 minutes for the low-risk mama. True or false? Pain experienced by a woman in labor is fairly intense. False. Pain during labor is a universal experience, but intensity varies. True or false? If a pregnant woman in labor calls the healthcare facility, the nurse should strongly advise the woman to come to the facility to be evaluated. False. You will definitely not have her come to the facility. The nurse needs to ask her about her signs and symptoms and what she's experiencing, and you're going to be doing a lot of education. During the second stage of labor, assessment would include which of the following? The answer is A. During the second stage of labor, the nurse would assess for signs typical for this stage, such as complaints of rectal or perineal pressure. The assessment of estimated date of birth, fundal height, and fetal position are assessments for the first stage of labor. And that is all. If y'all have any questions, y'all know my number.